Welcome, everybody. Happy Friday. We're very, very glad to have Dr. Megan T. Ebor today. I'm going to give a very brief introduction and then I'll let her take over. So Dr. Megan T. Ebor is a PhD MSW and an associate professor of social welfare at San Diego State University and the founding director of the Health Equity Research, her Multimedia Lab. She earned her BA in sociology, her MSW and PhD in social welfare at UCLA. Her research focuses on improving sexual health outcomes for African American women and older adults in communities of color. As a social and behavioral change communications SBCC practitioner, she develops behavioral health interventions using multimedia platforms to promote health and wellness. By merging science with narrative storytelling, Dr. Ebor creates health communication films that make public and mental health research accessible to under-resourced communities, addressing health disparities and at the intersections of age, race, and gender. An award-winning filmmaker and scholar, her work is driven by a commitment to equity and social change. We are very excited to have you here and looking forward to hearing your talk. And whenever you want to share your screen, go for it. And if you're not sharing slides, that's totally fine too.
Okay, great. Thank you so much for the introduction. Good morning, everyone. It's an early rising time. And this is quite a spicy topic for 8 a.m. in the morning. But I wanted to just kind of acknowledge those of us that are here in the room today. I like to be grounded and settled before we begin. So just taking a deep breath in and out and in and out. So thank you again for joining me in this early morning. So I'm going to jump in. We have a lot to kind of go over this morning. So I'm going to share my slides and let's see, I'm going to share my slides. Okay, can you all see that? Let me put it in presenter mode. Okay.
Perfect.
All right, now I need to hide myself so I'm not in the way. Okay, so Unclutch Your Pearls, Confronting Biases in Sexual Health and HIV Care for Older Adults. So I just wanted to say that Unclutch Your Pearls is a series of presentations that I do for varying audiences, for students, for clinicians, and it's tailored to each audience. But this is a training that we do through the lab. So you'll be getting a condensed version of Unclutch Your Pearls. Okay. Let's see, how do I advance my slides? I guess down here. Okay, so disclosures, I have no conflicts of interest to report. Now, this is the other thing. Before we start, I'm trying to think, how do I get back to the chat? And in the event I need to share a link. Uh-oh. Sorry, guys. We're going to get this.
It should be at the bottom,
okay.
But it might look different on yours.
Yeah, it's different on mine. So before we start, there's an activity that I must do before we start and before I begin to talk. So I'm going to share the QR code. You can scan that, and then I'm going to flip back so that I can put it in the chat. I don't see the chat button while I'm in this mode of frame. So I'm going to stop the share. I'm going to share the link in the chat. And then I'm going to share again with the QR code. Now, this activity only works if you're very, very honest and very, very quick with your answer. So I want you to scan the QR code, click the link, and be as brutally honest without thinking too much. Just quick response to the question on the QR code. And if you could give me a thumbs up once you're done. I'll give you a few minutes. Okay, we have one thumbs up. Okay. Get a few more thumbs up. Give you a few more seconds and then we'll jump right in. I love those thumbs up. Thank you. Okay. All right. I hope you've all had a moment to respond to our question. We'll look at the results later. But for now, I would like to share with you some results that we've gathered along the way. So the question was, what is the first word that comes to mind when you see the words 82 years old? Now, we just came back from the International AIDS Conference in Munich. We did this presentation and I shared this slide. And these were some of the responses that we got. Now, what are some of the words that stand out for you all? If folks are responding in the chat, please chime in, Anik. So what stands out to me? Old is really big in the middle. Wisdom, that's a great word. Ineffective, oh, that stood out to me. Marginalized, gray, sickly, oh my gosh, sickly. Long life, death. These are some of the words that first come to your mind when you think of the word 82 years old. This was for a global audience. Now let's look and see as we look for, now this was another conference presentation. These were sex scientists. Let's look at what they think about when they hear the word 82 years old. What stands out to you? What word on this word cloud stands out? Frail, white-haired, happy senior in Florida, blessed, that's a good word.
Dances bent.
Bent, oh gosh, yes. Hairy ears, dealing with health issues. And this was a group of sex scientists. Now let's look at another. Now I've been doing this, collecting these words from this word association for quite some time. Now this was for emerging clinicians. These are students that are earning their MSW or their nursing degree, or, I mean, these are the words that came to their minds when they first saw the words 82 years old. What stands out for you? I see boring, deaf, grumpy, medication, wise is a good word, AARP. I just started getting those in the mail. Bitter, deaf. How many of us would want to be this 82-year-old?
Thank you.
Yeah, no, thank you, right? So why are we doing this? What is the purpose? Why do I have folks engage in this activity? When we think of the title of these talks, this training, the pearl, unclutch your pearls, right? Let's what is the definition of clutching your pearls? It's disapproving, right? To behave as if you are shocked, especially when you show shock that you really don't really feel, something, you want to show that something is morally bad. And oftentimes this can come up for us in our practice, right? So when we think about the words that first came to our minds, which we'll maybe revisit at the end of our session, let's sit with the words that you responded with. But when we look at the responses of the other folks from the other presentations, let's think about how what we think impacts how we show up in practice. If we have that 82-year-old sitting in front of us, what are the thoughts that are first coming to mind? What are the assumptions that first come to mind about a patient, a client that may be of age? So let's define ageism and sexual ageism. Did we know there was a difference? Did we know there was a difference? Can you guys still see me and hear me? And the slides?
Yes, perfect.
Okay, because I just took all of you off my screen. I can no longer see you or myself. But defining ageism and sexual ageism, I think it's important to make the distinction between the two because ageism refers to stereotypes. That's how we think, prejudice, how we may feel, and then discrimination, how we act towards others based on age. And that definition, I love that definition, comes from WHO. And that was 2021. Then sexual ageism is slightly different. It's the societal stigma that older adults no longer have an interest in sexual intimacy with others, right? So older adults are stereotyped as being what, non-sexual, not capable of having sex, not capable of having or enjoying their sex life as when they were younger. So you may be wondering, okay, this is bright and early in the morning, Dr. Ebor. So why is this important? Why do I need to know about ageism and sexual ageism? And as we continue throughout this presentation, I want us to really be thinking about how we show up in practice and how we show up in terms of our feelings, what we think, what we believe, and how we act, perhaps toward an older clientele. So ageism has been associated with a lifetime depression. So the mental health implications for ageism really are impactful. You can see increases in depressive symptoms over time, anxiety, social isolation, and loneliness, right? And then sexual ageism, it can thwart HIV testing and screening, right? So if you don't believe an older adult is engaging in sexual activity, or if it's very uncomfortable for you and you just don't want to go there, you may not test as frequently or screen for HIV and other STIs, right? So it can also impact provider communication related to sexual health. You may not want to speak about it, or, the communication can be thwarted because of the thoughts that we have about, or the assumptions or the biases that we may have about an older adult. So, and it can also cause loss of interest in sex due to social stigma. So, sex among older adults. Okay, we're getting a little spicy. I know it's a little early, but I wanted to show just some beautiful imagery of varying couples and groups that among older adults. How beautiful are these images, right? We may not have thought about this depiction of an older adult when I first asked you, what is the first word that comes to your mind when you hear the words 82 years old, right? So these are, just wanted to kind of give you a visual. Sex among older adults. So sexual, now this has been researched and there have been national pollings for healthy aging just to kind of demonstrate that, yeah, older adults are having sex. And if they're not engaging in the actual act, I mean, there's sexual intimacy that older adults also engage in. That's very important for healthy aging. So let's look at some of the numbers. So age 75 to 85 years, sexually active, 54% reported having sex 2 or 3 times per month. And then 23% reported having sex 1 or more times per week. So AARP, Healthy Aging Poll, ages 65 to 80. We look at that, right? 67% said that they're interested in sex. And then they also specify that it's important for their quality of life, right? So sex includes adaptive activities, is what I was kind of mentioning early. So the adaptive activity, which could be partnered and unpartnered, right? Physical and emotional intimacy, masturbation, as well as penetrative sex. Sorry, my mouth is getting dry this morning. Sorry. So STI rates have increased in ages 55 and older. So this here, I think, is very telling. We know that older adults have an interest in sex. We know that they are engaging in sex, and we know that this is okay, right? This is actually great for their healthy aging. So I pulled this slide because I wanted to kind of demonstrate this in terms of HIV and what's happening with the numbers. I know a lot of the doctors on the call today will want to see where's the data. So in 2020, 2021 compared with 2017, this shows the changes in numbers of diagnoses of HIV infection. Now, this was attributed to male sexual contact. But look, if you look at the numbers, the only increase was amongst persons age 55 and older. That's very telling. So stigma, I know we hear this word all the time. I know that this does not apply to the folks on this call, wink, wink. But let's go over it just one more time for good old time's sake, right? So HIV stigma, that refers to the irrational or negative attitudes, behaviors, and judgments towards people living with or at risk to HIV, right? This can negatively impact the health and well-being of people living with HIV. And the last bullet point I think is super, super important. They're all important, but the last bullet point, you know, when we're looking to end the HIV epidemic, right? This stigma has been such a barrier and has been written about extensively as a barrier to care. And so when we have stigmatizing beliefs or use stigmatizing language, it may discourage some from learning their HIV status, accessing treatment, or staying in care. So I wanted to kind of switch gears just a tad, just to kind of get us ready, because I'm going to now discuss the work that I do, which really I look at the stigma component in an intersectional way, because there's multiple statuses that can be stigmatized. And the way I look at this in my research is from an intersectional framework. So multiple marginalized social statuses based on HIV, gender, race, and age, right? So my work specifically focuses on African American women and of age. They're older adults, 50 and older, right? So stigma is further complicated by ageism. Now, we talked about ageism a few slides back. You know, that's the part where that's how we think, which impacts how we feel, and then how we act, right, towards others. That can greatly impact the way that they see themselves and the way that you see them, and then the care that they will receive. Stigmatization may lead to, now, the last point, just please, let's just read that and reread that, right? Because stigmatization may lead to a healthcare provider oversights to mental health and sexual health of older adults, right? So it's very important to know how we feel, and what we think. Hence the word association activity I gave you in the beginning. I really wanted us to kind of maybe put it out there, how we initially feel when we think about an older adult, right? So let's go to the next slide. So I wanted to bring in my focus so that we can really get into the work that I do in terms of my research among Black and African American women. If we look at this, look at these numbers. I mean, like this bar graph just shows African American women just all the way over. We're at 54%. We represent. And then if we look at trends by age, you see most of these were down. Most age groups, 25 to 34 stayed stable. And this was, and here, 55 and older, just up, right? That was 2019. So I wanted to share with you just a brief little snippet of the work that I do so that I can show you some of the data that I have collected and some of the outcomes from our qualitative analyses. This is the trailer to my first film. Now, this film, we have since done an update on this film, but this is the original film from some years ago. But I wanted to share this, just a small trailer with you to just give you a glimpse of the work that I do using health communication film and documentary filmmaking. So let's take a listen. Uh-oh, you need to go back, hold on. Play, okay.
The largest group of growing HIV positive cases are women over 50.
I'm 62 years old. I still have sex. Yeah, it's not on a regular basis, but it's when I want it.
I'm going to be sexually active until they put me in the ground.
I'm 58. People think, well, grandmother's not going anywhere. I still have urges and I still would love to be loved.
It's okay to be sexually active. Sex is good, right? It's part of our human nature. But let's be real about what can happen.
We have a huge demographic that's growing by leaps and bounds. We've got this big gray tsunami coming.
I never did use condoms because I always felt that if a woman looked clean and smelled good, that they was okay.
Do you know anybody that has had protected sex for the past 30 years?
It's hard to live in a world where you're afraid and you can't talk about it freely.
Oh, I heard about this truck, so here I is.
Okay.
Coming to get tested.
Sure, come on in.
Okay.
So this is your first time being tested?
My first time.
There is no excuse no more. But that's the excuses that they use. I want the real deal. I don't get the same sensation. Shop for the right condoms and you will find one. Get creative with it.
So that was Even Me. That was the trailer. I hope the sound worked well. I tested it before we got on, so I hope that you were still all able to hear. But that was the trailer to my first documentary, Even Me. And these were some of the film festivals and awards that we won. And these are the ladies from Los Angeles that were in the film. So, but sex in older adults, let's really talk about it, right? This is a publication that we wrote from data we collected here, HIV awareness and knowledge among viewers of a documentary film. And then here, I wanted to share this because I thought you all might think it might be useful in your practice, but a couple of colleagues of mine, mainly Dr. Sutton, this was at the National Medical Association where they did a questionnaire questioning providers, medical doctors, on their use of brief sexual history assessments. And they found that a lot of work needed to be done in this area with having a tool that was short, brief, that folks could just fill out when they come into the office, where you can use for screening purposes so that you can know and assess ahead of time before seeing the patient whether these discussions or what needs to be discussed as your client comes in or your patient comes into the exam room. So I wanted to show this so you could all see that and share that. And the reference for that is in the end of the presentation. So I wanted to just share results. So we show this film, we use it as a tool to bring awareness, education among varying audiences. And this particular study where we used the film, we had pre and post test. We had both, it was mixed methods, but for today's presentation, I really just want to focus in on the free text question that we incorporated into the questionnaire, which states, please indicate what you've learned today that you did not know prior to watching this film. So for the pre-test, we had 333, post-test, 341. Some people trickled in late, so they didn't get to do the pre-test. But from that, our free text query respondents, we had 193. And as you can see, most were students and most were in that age group of 19 to 29. So some of the qualitative themes after our analyses that came up were one, increased awareness of sexual ageism and stigma. Two, improved motivation for changes in practice professionally and behavioral change. And three, awareness of the need for sexual health communicative skill development. And I just wanted to share some of the responses that we received. So for increased awareness of sexual ageism and stigma, one of the respondents said, I never really gave thought to the 50 plus population as being as sexually active because I didn't think that they were physically able to engage in sexual activity. This one really gets me because, I mean, when we think about that, 50 plus is 50 is not really that well, we're going by the CDC surveillance data. So they use age 50 as an older adult. That's why I use the number, but I'm almost 50. So I'm like, oh my goodness. No, but yes. Never really thought. So I thought this was a really good quote to share. And let's just move on. So for theme 2, improve motivation for changes in practice professionally / behavioral change. So I learned that as a clinician, it is very important for me to deconstruct stigma and respect the beauty of sexual intimacy in older adulthood. And this is what folks are responding to after watching the film. I learned that I need and must get more comfortable and ask questions to my clients, all of them, regardless of age, about safer sex and HIV status, and provide them with info, regardless of their answer. I thought that was super good. And then our theme number 3, the awareness of the need for sexual health, communicative skill development. STIs and safe sex practices are very important topics within the older adult population and should be addressed, talked about more often. So these were just some of the responses that we received after engaging in the film screenings and then also doing some discussions and Q&As after the films were watched. So what are the data summaries and next steps? We're wrapping it up here. So our data summary and next steps: increase awareness of sexual health disparities, right? We talked about that in the work, how some groups are more impacted than others, particularly African-American women, and the African-American community at large are disproportionately impacted. The importance of moving towards more health equity, right? We want to normalize sexual health and wellness conversations with older adults, increase engagement of clinicians in sexual health research and routine clinical activities with older adult patients. And we also want to test sexual wellness interventions with clinicians in settings with older adult patients. Here's my references. There's an acknowledgement, a little shout out to Dr. Sutton, who always supports this work, and she helps me pull some of the slides and some of the data. So I always want to acknowledge Dr. Sutton for her support of this work. And then questions. We can go to Q&A.
Thank you so much, Dr. Ebor. That was really interesting. And sorry, I mispronounced your name the first time.
No.
Before I forget, Dr. Aldos was asking if you could share a link to the documentary, if it's available for people to watch.
Yes, you can send me an email. I can send you a link and a password to watch the entire doc.
Amazing.
Yes.
And I see Dr. Wilkin has his hand up, so go for it.
Thank you. That was really great. So as far as the documentary, so you viewed that in a way as an intervention for providers, and which is terrific. And then I was wondering, still some of what's talked about is sort of HIV prevention, STI prevention, which is, of course, very important. I was just wondering if there's any work towards really more about, promoting sexual wellness. So, what's going well with sex, what's not going well, how do providers kind of support that, taking it away from just STI diagnosis or HIV prevention.
Well, I'm sorry, I don't know. Can you repeat what the question was? I have some thoughts, but I want to make sure I answer your question specifically.
Well, so, often like you can ask like how things are going with sex, sometimes, we prescribe Viagra or whatever to kind of help men with sexual activity. I'm just wondering if there's other like broader approaches to take it away from just diagnosing STIs, but how do we as providers promote, fun, enjoyable sex?
Yes. Oh, I love that you asked that, because a large part of the work that I do. And in partnership and in collaboration, I mentioned Dr. Sutton in the beginning, who just wrote a book about joyous and sex. And it's a best-selling, she received a best-selling author on Amazon, but really promoting it's sexual health and wellness, and that's the message. And that's the way that we approach the work that we do. Um, Prevention and intervention is necessary, but we also want to promote that a healthy sexual life is a beautiful thing. And I think we as clinicians and providers can, once we start to break down the barriers, the discomfort, because I find that most patients want to engage and talk about these things, but oftentimes don't feel in the room that it's up for or a topic for discussion. So I feel the more that we as providers or clinicians in whatever capacity we serve, if we have an open and free kind of dialogue where we normalize these conversations. And I feel through my film work, addressing our biases and the way we actually feel about sexual health in older adults is a gateway to kind of open the conversations on how we can promote sexual health and wellness. So, and we do that. And like I said, this was a smaller rendition of the trainings that we provide, but we really get into, I mean, we really have a lot of fun with a lot of the activities and workshops that we hold in terms of unclutching your pearls so that we can promote more sexual health and wellness and joyous sex.
It's great work. Thank you for sharing.
Thank you. Anybody
Gonna
else?
I'm gonna be boring and get back to the STIs. I was wondering if you had any thought of why these rates are increasing. Is it more access to diagnosis, or is it more sex, or is it more unprotected sex?
Well, for older adults in terms of HIV, and actually I just wrote an op-ed around older women and syphilis. You got to guys go find that, and it's in the San Diego Tribune. Just wrote that because the increases, I mean, sexually transmitted infection in terms of syphilis with older adults is the highest it's been since the 1950s. And that's the op-ed we just wrote in San Diego Tribune. But that is attributed to the screening. We're not screening for it, right? And I think that that can tie into the assumptions that we may have often. I don't want to blame us per se. It's not a blame, but if we're not screening, then we don't know. If we're not having the conversations, then we don't know. If we don't open the conversations, I know the client and the patient has a responsibility as well, but I think we can foster an environment where these conversations are, they feel that they can talk to us about these things. So STI, and for HIV, heterosexual sex is like the number one for for older adults. Like they're having, sex unprotected, and the rates are increasing.
Thank you. Nettie, do you want to share? Do you want to unmute? Okay, she might be.
Yes, sorry. Can you hear me?
Yes, perfect.
You could just read my comment. I was just agreeing with the comments about, asking about pleasure and all of that, and, not just talking about STIs and risk. I mean, my point was like, yeah, of course, we are an STI clinic. We're STI doctors. So like, yeah, it's going to come up. It's the reason the person's there. So we don't need to smash them over the head with it. Meanwhile, we can ask about, especially with menopause, we're starting to pay more attention to women in menopause and asking, if they just say, oh, I'm not having sex. It's like, well, do you want to have sex? Are you having any challenges? Do you have vaginal dryness? Like there are treatments and things we can do to help people have healthy sex lives. So trying to pair that message or even open with that message and then follow with the prevention and STI, message might be more patient-centered and effective.
Love that. Love that. And, too, for the work that we do in terms of African-American women, we just received a grant through Gilead, through the PACE initiative, to do some of this work through sister circles and having these broader conversations about sexual health and wellness. and less about risk, but reasons, right? They have a campaign called Risk to Reasons. So we're really beginning to reframe the way we address sexual health amongst across the lifespan. But this particular grant we received through the PACE initiative, it's across the age, the lifespan, and then also all women. So it has cisgender women, trans women included in that outreach. And we do this work through innovative modalities, through sister circles and film screenings. That's the arts and advocacy piece. And so that we're not just focused on the vulnerabilities, the risk. Oh my God, you're going to, it's not from a fear tactic, but it's from a sisterhood and where we can embrace, ask questions and learn and really promote sexual health and wellness.
I'm gonna read Dr. Wilkins' question, and then I have one myself. But he was wondering if there was any work on doxy-PEP or on-demand PrEP in older adults in terms of acceptability, feasibility, safety.
I have not come across that, but listen, I'm always open. And I see Dr. Miley on the call and I see Dr. Stockman on the call. Listen, there's so much work to be done in those areas. And listen, I would love to partner to do some of it. So call me and let's do some of that work, because with the new medications that are coming up, I just had a call. One of my good girlfriends was just asking me, like, what do you think about these injections? And I'll tell you, I'll be 100% transparent with you all. Within the African American community, we have a lot of work to do to bridge the gaps and to bridge those gaps between research and community, because there's been a lot of hurt and there's been a lot of there, and I don't like to call it medical mistrust. I like to reframe that as institutional untrustworthiness, right? And I got that term from Dr. Blackstock. But I'll tell you, the institutional untrustworthiness is a barrier. Like even if we are aware of these medications, there's a healthy level of skepticism in our communities. So I really think there's a lot of work to do where we can mend and have some restorative practices so that folks can feel that this is a trustworthy medication. I can take these medications to live a healthy life and to better my life. So I just wanted to put that out there.
Miley, please go for it.
Hi, Megan. I just I just wanted to also comment about, at least anecdotally, a lot of my older adults are having, sex with people mostly because they're lonely and they just want to feel like they want a connection. Perhaps they've burned bridges with family, in earlier parts of their life, and they just want to connect with people and don't always have a lot of opportunity, particularly if they are not very mobile or don't have the means to go out and mingle. So that's certainly something, I think that is an issue that needs to be incorporated. I was also thinking, as I was listening to you speak, again, like this is such a great talk. We should definitely submit to American Geriatric Society next year. I think having you speak about this would be because the geriatricians don't like to talk about sex, like either. And they know that they're having sex. It's just they're uncomfortable with it. They don't know how to talk about it, and particularly in the context of substance use. So I think we'll definitely get together and do that. I bet I'm almost positive it'll be accepted for now.
Let's do that, Miley. And I'll tell you, if folks, I do workshops with providers, and we have so much fun, right? So I really feel that if we have the trainings, the workshops, the CEUs where folks can come, the trainings are so much fun, and we really just get into it, because if we can't open up and be honest and have these conversations amongst our colleagues, then we're certainly not going to have these conversations with our patients. So I think fostering a safe and brave environment where we as clinicians can have these trainings together, have fun, make it light, confront our values, our ideologies, our culture, because they all impact how we feel and think about these issues, right? About sexual health at large. But when we think about how it impacts our practice, that's where we have to do the work. And oftentimes, as clinicians, we don't have the space to do the work, that self work that needs to be done so that we can kind of be the most efficient and beneficial to the clients that we serve. So just wanted to put that out there too.
I'm giving some space for people to ask questions, but I'm gonna ask one if.
Okay.
Yeah, I was thinking about the image that the picture of different couples that you shared, and the fact that there's very little, yes, kind of exposure to that in the media. We rarely see older adults having sex in films, and older actresses in particular, like, I mean, Nicole Kidman or Jennifer Aniston still look like they're 25. So I was wondering if any of your work is focusing on changing that exposure to different body images when you're older, and that being fine. I remember one film where Emma Thompson is a lead actress, and I don't know if you've seen it, but it's like Good Luck, Mr. Joe, or something like that. And she becomes a widow, and she hires a male sex worker when she's, I think, in her 60s or 70s. And we see her fully naked in the mirror with all her C-section scars, and that's the only example I can think of. So I was wondering if you're doing work in that area as well, or if that's part of the workshops with the systems.
Well, and thanks for asking that, Anik. You know, I haven't. I tend to try to do it through the work that I do by amplifying the voices of older adults in the work that I do and the film work that I do. But I will say there have been more recently more programming geared towards older folks. And I'll tell you this, those in the industry, I mean, we live in La La Land. So, of course, the plastic surgery capital of the world, right? Folks want to remain young, but I think the industry is catching on to the demographic shift. Like, we have to start tailoring this work or filming and media towards an older population, because this shifts. We're going to have more older adults in the United States than younger people at one point, by what is it, Miley, 2030. So what I would say, like, Frank, there's a show that's on Netflix. What is it? Frankie and something in Frankie, but it's I watched the episode.
Grace and Frankie.
Grace and Frankie. It's so hilariously funny, and watching their stories, and then what the dating show that's geared towards older people now. There's a dating show. Yes, I forget but I mean, folks, I think, are slowly catching on, and how to have representation of an older population in a non-stigmatizing role. You know, I think people are starting to catch on, but I think there's still a lot more work to do.
I see a question by Aaron. Do you want to unmute yourself, or should I go and read it? Whatever you prefer.
Can you hear me?
Yes, perfect.
Yeah, I thank you for the presentation this morning. I've been thinking a lot about the data you presented, and I'm curious, what are the barriers that you experience to trying to get more enhancement in the medical training programs, in the medical curriculum? Because I'm looking at the data and I'm seeing, the conscious bias, but I'm also seeing this huge gap in our medical training programs. And so besides just trying to change the practice of practicing healthcare providers, investing in the education of the new providers that are going to be practicing, to make sure that they're getting a higher bar in their academic training than the rest of us have gotten thus far. What are the barriers to trying to make that work happen?
Aaron, thank you so much for asking that question, because it's so important. And I'm just thankful that you asked, because it's not only in the medical field, it's across disciplines, right? And when you look, I just submitted a paper, just addressing healthy aging and how we just always omit sexual health. Like, we have all the other things, right? And no one ever really talks about sexual health. And and it's a shame because I'm like yelling from the rafters, like, hey, we need to include, and I feel so all alone. And that's why I like to come hang out with like Miley. Miley gets it, right? So, but there's a lot of barriers, I think. And now this is anecdotally, but I really feel that the discomfort lies with us. Like, if we don't feel comfortable in our own skin talking about it, we won't prioritize it. And there are so many variables that are in play there. Because when you think about who we are, how we were raised, our beliefs, our values, our ideologies, and in social work, I'll tell you, I pound it into us because it's like we're one of the disciplines that kind of are forced to deal with the self. Like, we encourage our students to be in therapy when they're practicing to be therapists, right? And then I bring in as much as I can as, a professor, but I think we should start with us as clinicians and how we really truly feel. That self-awareness is such a very important component that it impacts everything that we do, but yet so little attention is given to that assessment of self and getting to know the self and how the self can impact the way we practice. So the more we know about, and that's why I really threw out that question in the beginning, and I want to remind me to show us our responses. How do we feel about the number 82 years old, right? Because if we don't know where our biases lie, how we truly really feel about that number, is it scary? Do we think of death? Do we think of dying? Like, what are the visuals that we see of aging? And then how do we think about healthy aging? And what are the variables that are at play when we think about healthy aging? And across the spectrum, sexual health is important, right? It's important for a lot of folks. Now, I won't say it's important for everyone. There are some folks that are like, I don't want to deal with that. I did it all my life. I'm done, right? But for the most part, as we see from the data, folks want this information. So I really feel if we get the right players in place to prioritize sexual health in our trainings and our curricula, I'm a lonely soul person trying to let people know, hey, this is going to be an issue if we don't deal with it. And having opportunities like this, I'm very super grateful for, because all of you on this call can play a role in helping to prioritize this topic, this issue, and getting with folks that are doing the curricula and making the accreditations. Like, folks need to know about this stuff. But what I can say, Erin, just to sum it up, because this is a long answer to it, but just to summarize it, I am hopeful, because the younger clinicians and providers coming up, they're like super comfortable with this stuff, right? But we need to do our part and provide the training around it. I think they're more than willing to have these conversations. They don't have the same, and I want to say generationally, they don't have the same hangups that we may have as, folks that have been in our careers for a while. They're ready. They're primed and ready for this information. We just have to give it to them. Miley has her hand up.
I just wanted to comment that, from a more systemic level, so New York City is actually incorporating older adults as a priority in their ending the HIV epidemic efforts, even though technically they're not really a focus and has never really been a focus to EHE. But they've recognized that because, we're still diagnosing older adults with HIV later in their stages. They're the highest group that's presenting with AIDS when they're diagnosed. So, I think, Megan, all your efforts, California, unfortunately, tends to follow New York instead of leading the way. But I think, we can use some of what they're doing and some of your work to really get some policy going here so we can prioritize our older adults too.
Yes, Miley.
I'm also gonna mention Sarah's comment in terms of she really enjoyed your film and she thinks it's a great training tool. And she was asking if you had reached out to the internal medicine and family medicine residencies, and also asking when can we have a San Diego debut of the second film.
Listen, we're currently on the festival circuit, which I'm super, super excited because folks, I get excited when this work resonates with varying audiences. So we've already received 10 official selections for the second film. We're going to be in the Awareness Film Festival at LA Live on October 5th. So if you want to take the drive, it would be great to see you there. The first film, I mean, listen, you guys just have to email me and let's schedule it. I'm always ready and willing to share this work because it's critically important and not enough folks have access to it. So email me and let's put it on the books.
And in terms of reaching out to internal medicine and family medicine residencies, is that work that you know?
If anyone wants to invite me to come and do a presentation, I would be more than happy to do that as well.
Thank you. And then David Grelotti asks, what do people think about medical coverage for sexual health? Who do you refer to for sexual health problems? What are the evidence-based practices? Are they covered by insurance? And he says he often hears that the usual meds like sildenafil, I don't know if I'm pronouncing it correctly, are not covered. So basically a question about insurance.
Miley, you want to take that for me? She's the one providing the medical stuff.
I mean, I think some of our patients are definitely getting sildenafil covered. It's also generic, so it's cheaper than it used to be, but they only get like 10 a month, which I think is the issue. So, you know, the urology has now a men's sexual health program. And I think OB, I don't know if Jill's on. Jill's probably on. Is Jill on?
No,
Jill
Jill,
might know.
she couldn't make it
Oh
today.
no, oh no. So Jill probably knows more better than me about what OB is doing, but OB definitely also has referrals or will take referrals for female sexual health issues. So I think if anyone is actually having issues, you know, at least at UCSD, I would recommend referring to either one of those groups. Oh, sorry, Dave, did you want to make a comment?
No, honestly, I do think that because I'm on the ADAP committee and we've tried to push getting sexual health medicines on the ADAP formulary, and it's gotten some resistance. But it looks like when we look at ADAP across the country, the only ADAP formula that we have access to that is actually covering it is Florida, but New York isn't, Texas isn't, Connecticut isn't, a lot of these other states, and I don't think it's on the medical formulary either. So that's why I was just curious what people thought about that mostly.
Does anyone know if it's on Part D? Probably not, I would guess.
We had some comments in the chat. Adam says, my patients often pay for it out of pocket with good RX coupons. It's pretty cheap. And Net says, I think the biggest barrier is in not assessing patients for these issues. Otherwise, prescribing vaginal estrogen and ED meds is easily done in the HIV primary care clinic. But yes, please add to ADAP. And there's a lot going on in the chat. Adam responded, but when I've spoken to insurance companies, they say it's not a medically necessary benefit to cover meds for erectile dysfunction. My patients and I would disagree, as would I. Yes. Okay, it's 8:54. This is a very great conversation, but let's share our results from our initial question. Is that okay?
Go for it.
All right. So this is what we all had to say this morning. Gentle, long life, hardship, fabulous. Oh, I love that. A lot of people said old, elderly, frail. Those were the biggest. Lonely, elder, ouch, death, gentle, and wise. I like that, wise. So good responses. Anybody have any reaction to our responses about 82 years old?
Nettie is asking for your email, but Marvin already shared it a while ago, Nettie, in the chat. Let me just find it again, but it's somewhere up there. Otherwise, we can just email it to you, but But yes, thank you so much, Dr. Ebor. I don't know if anybody else has pressing comments or questions. Sarah, I can see your video is on. Please go for it if you still have a few minutes.
No, I was just waving goodbye. It was wonderful. Thank you. How are you?
Good.
I really enjoyed the film, and this talk really made me think more about how do we disseminate it to the people that aren't thinking about it, because most of us here in the HIV world, we talk about sex all the time. It's all I can do not to sound like salt and pepper when I walk into an exam room. Like, let's talk about sex. It's like almost the first thing I want to do, because we really can't have overall wellness, right? If we don't have good sexual health, even for our patients who that's not what they're doing right now, but we have to have open conversation. And I think you're right. Getting trainees who are wide-eyed and open-minded is a great point of contact and training.
Yeah.
So there's lots of training programs in San Diego that we could probably help get you in touch with for the training. I think that's a great place to start. And then letting those that are interested in policy help us get those meds, because that's been a long struggle, and that's a struggle regardless of private insurance or state or government funded insurance. And then those of us who live in, I've learned how to prescribe, just like Adam was saying, how to get the lowest cost for patients, including, so for those of you that haven't really, that maybe don't do it as often, if you do a 30 tab supply of sildenafil, along with a good RX, that's the cheapest way that your patients can get it. And doing the less, like 9 or 10 tabs a month, actually makes the cost per pill increase. So I say, just get your 30 and then use it when you need it. And yeah, I think there's definitely education still to be done on how we help people and move from more of like a risk and trying to gather information, and then more of like how do we improve and augment the sexual health of our patients. And that science is up and coming, but I think we're especially behind for our female patients.
Absolutely.
Thank you.
Thank you. We have 2 minutes left, and I just wanted to say thank you for holding space with me this morning. I don't take any encounter for granted. All of us that were on this call, we're on this call for a reason. So whatever that is for you, please take it away and share with others as you go about your day. And I appreciate this time. Thank you for having me.
Thank you, Megan. This was a great way to end this week. And you've got lots of thank yous and wonderful work in the chat. I don't know if you can see them, and lots of clapping hands. And Dan has moved up the technology level with like little flying things.
Very nice. Very nice. And please,
wow.
Yeah. And Miley, you owe me a call. I hate to call you out on everybody. Let's get that grant written.
Happy Friday, everybody. Thanks
All right.
for coming.
Bye, everybody. Thank you.